before a panel of international paddle, Richard Gralla, Crawford, Gascon, Decado. They're all here, and they're going to join us on stage. The goal here is for 4 residents, 4 interns, to spend maybe 5 or 7 minutes on their clinical cases. And this will spark questions. We will discuss the questions amongst the panelists. We'll try to come up with solutions and maybe come up with new management methods. So we'll first hear from Carole, and she's going to present to us her own clinical case. No gender parity here. We have 3 ladies and just 1 guy.
Robert's missing.
As an FYI, the interpreters do not have access to the presentations. Please bear with us. Case number 1, thank you. Thank you. Thank you to the scientific committee for giving me this opportunity to present this case. So this is a 70-year-old male. We followed him since 2006. He suffered from metastatic kidney cancer. The disease had progressed after 2 lines of anti-angiogenics, sunitinib and axitinib. In 2012, we decided to include him in a phase 1 trial evaluating a PD-1 inhibitor administered every 3 weeks. This patient is fit and eligible for inclusion in a phase 1 trial. After the first cycle, neither dose-limiting toxicity nor toxicity was reported. We continued the treatment, but as early as cycle number 2, joint pain began, grade 1 arthralgia. So we kept up, and gradually polyarthralgia got worse. Following the various carcinogenic assessments and also the net benefit from the agent, we decided to continue the treatment. We used colchicine because we suspected the polyarticular gout crises. After 2 weeks of treatment, there was unfortunately no improvement, and the patient got to the ER presenting grade 3 polyarthralgia, and there was a clear functional and clinical impact. He could not cut up his food. He couldn't move about. He was bedridden. No signs of infection, no fever. During the clinical examination, we found polyarthralgia. The joints were swollen and painful at examination, local redness. The joints were tender, no evidence of spondyloarthropathy or connective tissue disease such as psoriasis or lupus. These are pictures of this gentleman's knee. And also there's a small joint in the right hand. As you can see, the dermis is impacted, the joints as well. And also, that wasn't the knee, my goodness, that was the elbow. An inflammatory syndrome prevailed. No real elevation of lymphocytes or leukocytes. Hepatitis serology, rheumatoid factor, anti-CCP antibodies all proved negative. We carried out an ultrasound examination of the joints. We found that there's a thickening of the synovial area, as you can see the areas, as well as a clear effusion in the joints, both the small and the large ones. And as I said before, there is no sign of infection to corroborate the diagnosis. So we found a seronegative polyarticular arthropathy triggered by the anti-PD-1 treatment. The patient was excluded from the trial. He was treated using corticosteroids, and there was a clear clinical benefit after 48 hours. The pain disappeared. He was able to move about again and go back to normal life. And these are the pictures 48 hours after the corticosteroid therapy and discontinuation of treatment. Fortunately, 2 months after we stopped the drug, the patient died due to the cancer progression. Thank you very much for your attention.
Well, I treat many melanomas more than kidney, and that's probably the so-called autoimmune induced by the so-called checkpoint inhibitors. And in fact, I'm surprised because PD-1 is supposed to have a better profile than ipilimumab. I have horrendous stories on colitis, etc., with ipilimumab. With PD-1, I find much more manageable. So I think this probably, I have hepatitis, I have thyroiditis, I have hypophysitis, uveitis, with all this medication, with the checkpoint inhibitors. So I think this yes fits with the picture that is not really an autoimmune disorder, but behaves like autoimmune disorder, and with corticoids most of the time gets resolved. So I'll set the stage here. Now you talk, fellows.
I was just going to, very nicely presented, thank you. And I guess I have more experience with lung cancer, but work closely with our melanoma group. I think the question here, and you were limited probably by the protocol, but can you treat with steroids and go back to the PD agents? And I think at one point we thought that wasn't possible, but now it appears to be. So people, particularly with colitis, have been treated with a number of immunosuppressive agents and been able to continue to benefit from therapy. So if this was off protocol and the drug was available, I would have wanted to reinitiate it once the patient's arthritis had improved.
But do you have with the same dose or maybe a little lower?
There's no data, but
quelle était la réponse de la tumeur?
How did the tumor respond? Well, needless to say, from a hepatic point of view, complete response was achieved, and for the lungs, partial response. So, based on this, we made a decision. Quality of life was severely impaired, and we decided to continue the treatment. So there was no response to the first therapy, to the first line of treatment. You mean anti-androgenics? No. We achieved stability, yes. For a long time, yes, but no response. But here, we had a clear response from the tumor cells.
It was very nicely presented in that your ultrasound shows that this is not consistent with gout because there is no effusion, and the thickened synovium does look different. It makes perfect sense that if one disturbs the immune checkpoint, that getting something that appears to be an autoimmune phenomenon can indeed occur. Of course, the curiosity is that you need the lymphocytes for the anti-tumor effect, and if the way that the supportive care is working, the steroid, is to eliminate lymphocytes, which it often does, then this is about as opposite as one can get. The question would be, can you even give the corticosteroid during the time of the anti-PD-1, or will this totally abrogate the effect? And I think that by having good cases such as this, we can start to approach the problem.
Yes, but I think nowadays, this is the beginning of the anti-PD-1. I think nowadays we will belong PD-1 and add the corticotherapy. So we do together the corticotherapy and the anti-PD-1.
Well, of course, the other thing to consider would be anti-PD-L1, because it would appear that an agent that binds to the receptor on the tumor itself and not on the lymphocyte might give, in potential, a different toxicity profile. Not to say those agents are without toxicity, but it could have been interesting in the same patient.
Yeah.
No?
I see in phase 1, clinical phase 1, the two, the anti-PD-1 and anti-PD-L1. I did in French. Alors, ils ont été développés vraiment, les
Yes.
anti-PD-L1,
Anti-PD-L1s have been developed because of their assumed better safety profile, but from a clinical point of view, it's not true. In terms of toxicity, they're as bad as anti-PD-1. The performance isn't better than for anti-PD-1s, particularly in phase 1 trials. We did not see a better safety profile for PD-L1s as for PD-1s. Maybe it has to do with the patient's age. In case of major toxicity, usually the patient is aged 70 plus, so maybe it is for these senior patients that we need to be more careful in terms of managing and administering the treatment.
To the fact that the anti-PD-L1s are without toxicity or anything, no, that's not so. But they have a different target. It's the same pathway, but a different target. And as such, for particular patients, we might see different results. Maybe yes, maybe no. Because if there is not a different result, then it would imply that our thinking is incorrect. And so, for instance, the pulmonary toxicity of the anti-PD-1s is felt to be, perhaps correctly, perhaps not, is felt that the type 2 pneumocytes have PD2, express PD2, and so that you get a cross-reaction. So therefore, an approach that looks at anti-PD-L1 should not really have an effect on PD2. On the other hand, we find with other monoclonal antibodies, including trastuzumab on occasion, pulmonary toxicity. So your point of the fact that these agents all share a different profile means that we can have the TAO meeting for many years to come to address these many toxicities.
Okay.
Other questions for this, about this interesting case?
Comment on the cost. Could you make a comment on the cost?
It's a fair question.
It's an unfair question. I forget the question. Let me make the comment. The pembrolizumab is at 1-point-something million per year in the US. And I think we have to thank our American friends here, because 80%, now pay attention now, 80% of the profit of the 20 largest pharmaceutical companies worldwide, 80% is price increases in the US. So if that was not the case, we probably would have to pay more. But then you don't want to pay for failures. We pay for failures. And this has nothing directly to do with you, but with the previous talk. I didn't have a chance to say something because Richard Gralla monopolized. But
That's the last comment by Professor Decato
for the week. For the week.
You're the chairman.
But I would just make one last comment, is that we are realizing now that we have problems of cost, but we have accepted for 10 years to prescribe drugs that give a statistically highly significance, that clinically are irrelevant. You know that all the angiogenic in the frequent solid tumors, you get 6 weeks. 6 weeks improvement of survival with all the angiogenics. So we were willing to pay for all that. So far, it's 6 weeks.
or less.
Or less, yes, or less, yes. So we're willing to pay for all that, but now we wake up and it's time. Thank you. Nice case.
Thank you very much, and it's interesting how we're integrating the last wonderful presentation with the current presentation, but in fact, when we present modern cases, thank you very much, we present modern cases such as this one,